Great. Thank you so much, Kathy, for organizing this session. I think it's exciting to be here to speak with all of you, and especially having a lens into what I think is really important collaboration that we'll need to do as a team to get people healthier and vaccinated and access to care. So I'm going to start sharing slides, and I'll be using the slide deck together with Jen. So give me a moment. And if there's any issues with the slides, just let me know. But I think you should be able to see the slides. Yeah. Okay. So we're here to talk about RSV vaccine. We'll also talk about the RSV options that are available as well that have become more available as of recently. So this is a really exciting time to be able to have some options. And so I do have some disclosures which are listed here. I do receive stipends from Pfizer for being on the Vaccine Advisory Board and for educational sessions. I do run research trials for Moderna and Pfizer at our institution, but the financial support goes directly to the research institutions to run the trials and personnel and not for personal use. I do receive grants from CIHR, and these slides were prepared and reviewed by myself and Jennifer today. I'll quickly run for an example because I think for many of you, you might have a different experience as to your first kind of medical interaction with a patient that sensitize you to the burden of RSV disease. As an obstetrician, I don't see young babies and I don't see, primary care to the same extent, especially during high-risk pregnancy. So to me, being exposed to this is through our patients when they come back after having had a delivery and they tell us about their story. And this is a type 1 diabetic who came back after a second delivery 8 years ago and was basically asking me for what we can offer to her to protect herself against RSV and her family. And she would be the patient I think of right away to offer this vaccine or these strategies today, because that's what she was looking for 8 years ago, and I didn't have anything to offer her. So it's certainly exciting to be able to have new options. I think given all the misinformation that comes around in social media, it's important to acknowledge and counsel our patients when we have the conversations that vaccine safety in pregnancy is not something that is new to us. It's well established as a role in our pregnancy management. And as early as in the late 1800s, it was noted that infants who were born to someone who had received a smallpox vaccine during pregnancy were themselves protected. So that role of passive transplacental immunity is well established, and that's what we've used in pertussis and tetanus to continue advocating for protecting the infant in that early immunity gap. We support use of influenza and COVID-19 vaccine to protect mom first, but we do know that there is protective effects to the newborn as well. And so I just want to highlight that it is important to keep an eye on monitoring of all of these vaccines in Canada. So being familiar with reporting systems that are available to us, that we can notify of anything that's outside the common side effects that we expect. So I highly recommend that people do put in any, kind of adverse events or cases through the Public Health Agency of Canada's Canadian Adverse Events Following Immunization Surveillance System. And there are other monitoring networks, but I would say starting there is really the right place. There are other vaccines that are recommended in pregnancy. I highlight them just because there may be situations where someone may come and talk to you about needing hepatitis B or A vaccine because of ongoing exposure risk or different outbreaks or places they're visiting. And those are acceptable as long as all vaccines are non-live, then they can be used in pregnancy as necessary. So the RSV vaccine that's specifically been authorized for use in pregnant individuals was approved on late December 2023, and it's to be used between 32 to 36 weeks. I think many here may be familiar with its use in the elderly population. That's been ongoing, I think, since this fall. We're happy that we do have now access to the NACI summary statement on prevention of RSV disease, which was published in May 17. The link can be easily found through the NACI statement. I also put here the patient-facing website, which is not available for Brisbane. In case patients who you're talking to want more information and different ways of looking at the vaccine, then they can access the patient information website through this link here. If anyone was in research in RSV, they are really celebrating this vaccine. The success of this vaccine is immense because of the journey to get here. It was discovered in the late 50s, early 60s, and there was an experience with kind of a failed trial in 1965. There was the first RSV vaccine trial that we're using formalin inactivated virus that actually caused more severe lung disease, and there was actually 2 cases of death. And so there was a pretty dismal result, very kind of go back to the bench work and start again type. And it took years to get to something that would be more successful. So the late kind of 1990s, that's when IVIG, RSV was approved and palivizumab became licensed. And that's what we've been using and have access to currently only for our high-risk infants. But the key to where we are today with newer agents is the identification in 2013 of the prefusion F protein that was mapped and understood that that's what kind of causes the host infection. And that's what led to newer strategies with nirsevimab and the RSV pre-F vaccines. I'm not going to spend too much on burden of disease because I think we all know the burden of disease well. I just think of one thing though. I think the general public now knows it a little bit more too because of the last few years, because after the COVID-19 restriction kind of lifted, there was that kind of massive triple-demic of all the viruses, COVID-19, flu, RSV, and I think that has sensitized people to understanding about RSV a little bit more. It is by far the leading cause of bronchiolitis and hospitalization in young infants and causes of pneumonia. More importantly, it can cause long-term sequelae of wheezing and asthma. Death is not as common in this age group, but in the older population it is. It translates to about 1 in every 5 cases of acute RSV-associated lower respiratory tract infections worldwide occurs in an infant less than 6 months. This is just to show that in that seasonal time, if we look at the, kind of November, March time, and you identify viruses, half of them are related to RSV, and it adds up to the sum of all the others. So it's a very important burden, and this pie chart represents it a little bit easier to follow. We don't even detect all the cases, so I think there are underrepresented burden of disease because not everyone necessarily has a PCR or a test for RSV, and they're treated with supportive care in the community. Given that the therapies we know that we're going to talk about have either a 6-month or a 12-month half-life, it's important to understand that, yes, that is when the infant is most at risk, highly concentrated in the first few months of life when we see more RSV hospitalization. I should add that there are kind of more strategies than what we'll talk about in development, but at some point we may have infant and pediatric vaccines. So you'll hear us say a lot to keep an eye on this sphere. There's going to be changing recommendations and new options. This is an important slide to show the high-risk factors for infants to be affected for RSV. So that'll be congenital lung disease, heart disease, cystic fibrosis, trisomy 21. So these are the current infants that will receive in the seasonal outbreak time palivizumab. I can't pronounce that well all the time. So that's who has some access to RSV protection. But what we're hoping is that we can protect everyone at a public health level, because although they're more at risk, when we look at the sheer volume and epidemiological statistics, it's really full-term healthy infants who are the mostly seen in hospitals. So they're really in numbers still much higher than all the other at-risk infants. This is just to reflect on the two dual kind of burden of disease. The left side pie is for the children under 5. The right side is adults over 65. And the children are more likely to be hospitalized and need care, less likely to die. I guess that's very thankfully, really. But for the adults, this is a reason for increased mortality. 1 in 9 of those who are hospitalized will die. So I think the summary is clear about why we need a strategy. We are going to talk a lot about cocooning, which I talk a lot about in our practice as well, that not just are you talking about immunizing and vaccinating those patients that you're taking care of now, but promoting vaccination of those around them to minimize exposure and disease. So talked about the prefusion F, so I think I'll take a moment to look at this virus particle. So it's a single strand RNA, and there's all the proteins on the surface. So similar to, like, if you can remember the spike protein, a lot of the vaccines were targeted towards this. Once they've really kind of sorted out this fusion protein's role, the protein F, which was like binding to fusion to the cells and allowing the virus to infect the cells and make its impact, then it was kind of where the target moved on. There are two co-circulating subgroups of RSV, so RSV A and B. So it's important to have protection for both. They are both just as effective to be a bad pathogen. And there's different types of strains that circulates in different parts of the world, but those will mix up as well. So it's not necessary that we have more. We tend to have more RSVA in Ontario, but that also can change. So that's more of a look at the protein F. And we've talked about how its binding capacity is the target to blocking the virus. So once we block that protein F, then it diminishes the viral entry into the cells. So the two types we've described, they're both associated with severe disease. And so the amino acid sequence are a little bit different, but the development of the vaccine applied using both the virus for the RSV A and B so that it can offer protection for both. So this is a look at the prefusion F vaccine. I think you're more familiar with this than I am, so I'm not going to spend too much time, but if anyone is not familiar and would like to see, because I think we have also some midwifery colleagues on the call, then I highlight this link for this video that would be valuable to view to understand how you reconstitute it, how long it can be stayed once you reconstitute it prior to given. I think it's 2 to 4 hours, and the storage. So I think those are important whenever someone's using them for the first time. I think some of you in this group are more familiar with this. So how does it work? So let's focus on the pregnancy part, which is probably why I'm here to speak to all of you. So antibodies are generated by mom. So you vaccinate the pregnant person or woman. That generates an antibody response with vaccine antigens. Those antibodies cross across the placenta. So that stage on the left, about 1 to 2 weeks. It's important to keep those timelines in mind when we're counseling patients about timing of the vaccine. And then the antibodies cross the placenta, the fetus receives the antibodies, then circulate in the bloodstream, and they confer protection up to 6 months. So that takes about 1 to 2 weeks. So you can see that a good 2 to 3, 4 weeks is needed to have that optimal response and generate those antibodies that circulate in the fetal bloodstream. The nice thing about this strategy, the fetus is born with that protection. We protect them from that immunity gap. That's what we're doing with pertussis. That's what we hope to do with RSV. I pause here briefly to comment on breastfeeding because I get this question a lot. I'd rather not take this now. I'm going to take this after. It won't apply to RSV. It could apply to COVID-19 and flu, but I'm going to take advantage of this counseling tip here, and I'll breastfeed, and that'll offer some protection. Yes, that's true. There is excellent protection with breastfeeding for many, many other things, and they produce IgA antibodies of the antibodies that you've produced, but it's actually not the same response. It's not the same protection. We're giving IgA antibodies that are circulating through the bloodstream when we transfer them through the placenta. The IgA antibodies from breastfeeding are great and protective, but not the same response. So it's important to give them that feedback. I always say both are great. You're offering continued protection with breastfeeding, and so having both is even better. Just will add that there's no breastfeeding information at this point on the RSV vaccine. It wasn't studied in the trial. We don't have breast milk studies. I can tell you from doing the studies, it's very complicated to analyze breast milk and get the proper results. So I can anticipate why they didn't do it, but we're hoping for more studies after to have that information for patients. I kind of described that earlier, so I'm not going to dwell on it, but it shows the timelines and that it takes a little bit of a sequence of time from the maternal to the infant transfer. This has been.
I'll jump into just from the lactation counseling and thinking about our midwifery colleagues that even in many of our experiences, if we've been individuals who have born children, sometimes your breastfeeding journey, especially if you're a first-time parent, isn't exactly what you expect it to be. And I know that there's a lot of responsibility that parents place upon themselves, and that could contribute to additional pressure if it was felt that appropriate measures weren't taken during pregnancy for that maternal fetal transfer. So I think in terms of supporting our patients and thinking about all of the ways in which we plan for the best, or we hope for the best but plan for the worst in these cases, that sort of strategy sounds great, providing, well, it doesn't actually sound as great, but could be a strategy. But what if it doesn't go according to plan?
Yeah, I think that's such an important point. And I think that theme we're going to talk about a little bit more, even if we talk about our other options. But it's really that also is key. I think is we all want that journey to work, but sometimes it doesn't. And then there could be some regret. And we really don't want that for any of our families. And I think what we want to continue doing is offering information on the safety of these vaccines that we're offering. So this is a long journey to get to Matisse, the trial that I'm going to describe to all of you, and then we're going to jump into a few other things. 2018 is when they started some of the first dose ranging studies. They went through all the usual, kind of bench to research that we do with phase 1, 2, phase 2, and 3 trials. All of the dose efficacy and appropriate formulation of the vaccines are done in phase 2, and then phase 3 was the Matisse study. So Matisse study was in 18 countries, 7,300 maternal participants, and we had 7,100 enrolled infants. It was over 2 seasons in the Northern Hemisphere and 2 seasons in the Southern Hemisphere. I like to be transparent when I give these talks. This was done, like you might have remember from the dates, they started in 2018. They were ready for the trial 2020. COVID-19 hit, the world shut down. So I think this trial would have been very different had it been done without restrictions. We probably would have seen much more higher numbers of RSV. Not probably, we would have seen. I'm going to rephrase that. And I think we would have seen a higher efficacy. I'm just suggesting this. I'm not sure, but my kind of scientific epidemiological background knows that this trial was affected by the timing, but they had all the money invested and everything set up, and that's just how trials work. There's still enough data here to make interpretation of the results, but I like to be transparent that we could have probably seen a lot more cases. So the primary endpoints we're looking at medically attended lower respiratory tract infections, the criteria being here for the less severe outcomes, and the more severe outcomes are listed here. So these means the patient or the enrolled participant comes into the trial site that they get assessed with very strict timelines that were already listed prior to the study starting, and they get a PCR to validate that it was RSV as cause. So they were randomized 1-to-1. It was participants less than 49 years old. They were between 24 to 36 weeks. So a little bit different than what we're using the vaccine in Canada. We are using 32 to 36 weeks. I will start to mention this because it's not published in the main paper that you will read that was in the New England, because it's not statistically significant. But the reason that the US and Canada have, out of caution, chosen to give the vaccine from 32 to 36 weeks, although it is safe and validated and studied between 24 to 36 weeks, is that there was 2 countries that had a signal that was not significant for preterm birth, and it was late preterm birth between 32 to 36. This was Argentina and South Africa. They actually had similar results in other trials. There's something maybe going on. Nothing has been able to explain those numbers. As I said, they're not significant, but because we want to be cautious, some countries have chosen to give it a little bit later and avoid giving it in the preterm. There's lots of caveats to that. We probably want to protect our preterm babies even more if they're born earlier. I think we'll get there. I think we'll have more experience with the vaccine and maybe feel more confident. I know that we're waiting on data from the use in those countries where there was those signals to see if they had higher preterm birth rates as to typical, to be able to understand how to move forward with applying. But I just wanted to talk about that briefly here. I don't think it's super important that it should come to life in a conversation with a patient, but patients who are really informed and dig deeper and have those questions, it's important for us to be able to address their concerns and answer those. So as you can see, 2023 late efficacy, this trial was published in 2023, April, I believe, of last year. And so when we look at maternal demographic, just like any trial, they were balanced groups. So no surprises there. I just kind of point out that over 32, 36 weeks is the most common group enrolled in the trial. That's not surprising. That's when we see patients more and probably more episodes of time to be able to recruit them in a trial. The infants had very similar demographics. In terms of tolerability, all the reactions were mild to moderate and were similar in both groups, except for muscle pain, which was more significant in the vaccine arm, and headaches. So really all were mild, and the adverse events reported at 1 month were similar in both groups, 14% in the vaccine pre-F group and 13% in placebo, with the most common things being vaccination site pain, headache, myalgias. And these were about 2 to 3 days in length and were resolved, just like typical to most other vaccines. Important to see if there was any signals to maternal deaths or fetal losses. All of these that are reported in the trial were found to be unrelated when they were adjudicated. So all were not related to the vaccine. One death was in the RSVF maternal group and had no relation to the vaccine. 18 fetal demises, 10 in the vaccine group, 8 in the placebo group. 17 infant deaths, 16 due to various causes. 1 infant death was adjudicated to be to RSV respiratory illness in the placebo group. So nothing that is worrisome, but certainly good to have access to that data. So this is for the primary endpoints, which I talked about earlier. I'll pause to say that all infants were followed for 2 years. Those outcomes for their follow-up were reported this past summer at RSVNet conference, and there was no differences, but that there's a separate publication for that. So if we look at severe medically attended lower respiratory tract infections, you can see that the cumulative incidence of RSV was lower in the arm that received the vaccine, and this was lower and sustained up to 180 days. What that translates to is a vaccine efficacy at 90 days of 81.8%, with the confidence interval being significant. So for this result to be interpreted as significant, the endpoint had to be above 20% for the lower bound of the confidence interval. And that was all the case for all of these timelines. So it continued to be efficacious up to 180 days, but there was a little bit lower of the percentile, as you can see here. When we look at the lower respiratory tract infections that were not as severe, there was also a reduction in the cumulative incidence in the vaccine arm compared to placebo, as you can see here. When we look at the vaccine efficacy, it was not as strong or significant in the 0 to 90 days. So 57% vaccine efficacy, but you would note that the lower confidence interval here is 14%. So it's lower than the 20%. So statistically, it's not significant. It does become more significant over time with the vaccine efficacy being about 56, 52, 51%. I'll make a comment that if any of you here read the NACI statement, this is what they use as their primary input when they compared the nirsevimab to, which is the monoclonal antibody to RSV pre-F. And I think there's a question as to why the severe outcomes weren't reported as well, because I think they're the more important ones as well, but that's just a thought to keep in mind. So in summary, we know that there's significant RSV disease. We know that the vaccine in this randomized controlled trial that is the first to include pregnant people in a vaccine trial, which is highly welcomed, and it's opened up the door to continue doing these trials initially on pregnant people and not rely on phase 4 and cohort data. So it shows high and consistent efficacy to reduce RSV disease. Of course, we need those activities of pharmacovigilance after to monitor safety, other outcomes that we've talked about, breastfeeding, longer term outcomes of whether there's reduction of asthma and wheezing in children and infants are very important to all of us as we start using this intervention. So I'm going to pause here, and Jen, I can pretty much switch slides for you and let me know if I'm slow on any of them.
All good. I'm not seeing any questions in the Q&A functionality just yet, so I think we're good to sort of go ahead and get into our Q&A towards the end. But if anyone does have questions that are really relevant to the slide, feel free to enter them as we go, and we'll address them all along. But I think when we talk about the innovation in the immunization space, it does get very exciting that we, in a short term have seen a lot of new options at protecting both, our infant population as well as our adult population against RSV. And at the same time, while it's very exciting and, in many cases, an informed healthcare provider population, options are a good thing because it allows us, more tools in that toolbox to combat the disease. I think it also introduces the opportunity for things like confusion and, the question around what to do. So in addition to maternal immunization, there are some other options for protecting infants against RSV. Of course, as Darine mentioned, we've had pembrolizumab for quite some time now, and those, I think, recommendations before the NACI statement had last been updated in 2022, but PAV was pretty much predominantly used in those very high-risk groups that had been shown within one of those previous slides with the bar graph. And in what we now have in terms of an option is a new product called nirsevimab that has been approved as passive immunizing agent. It's a monoclonal antibody for the protection of infants against RSV. We are still sort of awaiting details in terms of the programmatic level, which we'll get into. But ultimately, when we look at the two products, the advances with nirsevimab, it's a long-acting monoclonal antibody, which allows for a longer duration of protection with a single injection. Whereas with PAV, we previously had to administer every month during the RSV season to those high-risk individuals. PAV was weight-based, whereas the nirsevimab will have more standard-based dosing based off of weight, but really, and looking at those 3 standard doses based off of age and weight. So we're good to move to the next slide here. With the options for both maternal immunization and passive immunization of the infant with monoclonal antibodies, I think one of the questions becomes what do we do, right? What do you give to whom, when, and why? And we'll go through the NACI statement, but I think it is really worthwhile to go through what other jurisdictions are doing and what they've seen thus far. So in the United Kingdom, the Joint Committee on Vaccination and Immunization has recommended and has implemented a year-round maternal immunization program, which has been deemed to be preferred to ensure that there's high uptake for operational effectiveness. So ultimately, as we know, immunization, both based off of the timing within pregnancy as well as the seasonality, does increase the complexity, especially given the timeline and the other potential immunizations that are circulating within the community at that point in time, the time sensitiveness, that 4-week window, and that consideration that if at all possible, given the pharmacodynamics and kinetics of the maternal fetal antibody transfer, immunization closer to that 32-week period is really sort of more ideal if possible, especially given the opportunity to consider in some instances where it's practical co-administration with the Tdap immunization. But that ultimately that longer time to allow for that antibody transfer is more advantageous, but up to 36 weeks is absolutely part of that indicated age range. However, when we think about that potential of preterm birth and that opportunity, immunization earlier in pregnancy will provide more of that protection, especially if someone were to have a preterm infant closer to that 35, 36 week. Think about my own experience. I had a 35-weeker, and in that case, immunization at 32 weeks would have been sort of just soon enough in order to provide him with that protection. So with this, we also have the seasonal catch-up or year-round passive immunization program for newborns. So the nirsevimab should replace PAV because of its extended half-life within the UK program. Our neighbors to the south in the United States, ACIP has recommended the maternal immunization to pregnant people as a one-time dose at 32 to 36-week gestation. But in contrast to the UK, they're looking at seasonal administration to pregnant individuals. So still the 32 to 36 weeks, of course, but we are looking at administering that to pregnant individuals between September to January in most regions of the US because of the seasonality of the RSV season. So that approach to seasonality is sort of to provide the most bang for buck in terms of the immunization, because the rates of RSV, well, not non-existent, are much lower throughout those other times of the year. But it is, something to keep in mind that seasonal administration does sort of miss immunizing those individuals who may, still have RSV seasonality risk. We think about people who, travel to Southern Hemisphere perhaps and may have contact with different seasonality of RSV. There are the potential, of course, for out of season, sort of incidences as well. And when we think about things like, durability of protection, there could be that opportunity to have, some ongoing protection as we have more information about what that looks like with more data. So in this case, in the United States, it's recommending that the maternal immunization be used seasonally in accordance with the product monograph, and that nirsevimab is used in infants less than 8 months of age and children aged 8 months to 19 months who are at increased risk for severe RSV, beginning shortly before the start of RSV season. So once again, that seasonal approach. So what are we going to do here in Canada? Fortunately, we now have access to the NACI recommendations. And before we jump into what those are for RSV, just sort of a review of the language that NACI uses. When we consider a strong recommendation, we'll see language like should be offered, which means that it should be offered to most populations or individuals, unless they're in professional judgment, there's a clear, compelling reason to not, or to take an alternative approach. And in a discretionary recommendation often will be worded as may be offered. So offered to some populations, individuals, alternative approaches may be reasonable. And really that discussion around that, individual decision-making, shared decision-making with the patient, and that provision of the autonomy to make one's own decision in those contexts, of course, applies across all of these recommendations. But in those discretionary recommendations, the individual decision-making is sometimes a little bit more challenging for people, if they're in the lack of, sort of this strong recommendation that often will guide program level decisions. So for RSV, for the statement that we have from NACI, Darine, maybe if you wanted to contextualize anything that I say here, knowing sort of your background in this space, but I think most of us who have reviewed the NACI statement feel that it is quite conservative in nature. But that we are expecting, as Darine mentioned earlier on, that with advances in the evidence, the availability of other products and so forth, that we should likely see changes to this more frequently than we have in perhaps some other disease states that have remained more stable. In this case, we have a strong recommendation by NACI towards building a universal RSV immunization program for all infants. Of course, based off of things like access to supply, cost effectiveness, affordability, and that at this point in time, NACI recommends nirsevimab as the immunizing agent for infants over maternal immunization. However, if in the case of things like supply availability, there's concern that the infant may not have access to passive immunization through the monoclonal antibody, that the maternal immunization may be considered for that pregnant individual. That, of course, the prevention of severe RSV disease is done through the RSV immunization program, and prioritizing the most high-risk individuals as priority 1 groups. And then as well, too, though, that if cost effective, the priority 2 groups of individuals who are perhaps less at risk, but as we saw from the epidemiology, still significant system burden in terms of hospitalization and cost. And I think when we think about the average cost of an RSV hospitalization being about $9,200, when the cost effectiveness analysis shows that providing that if the product itself is cost effective, that immunization of all infants be a strong recommendation from NACI. And of course, that the maternal immunization may be considered as an individual decision by a pregnant woman or pregnant person in that shared decision-making process. And that's that discretionary NACI recommendation that, it may be offered. And I think this is going, yeah, go ahead.
Yeah, no, I'll let you finish your sentence, but this is where I have a few thoughts. But do you want to, was there something you were saying, or?
Yeah, I was just going to say, this is where it becomes more challenging as a community-based provider, especially with the approaching 24-25 season, where the information around program level decisions, funding, access, and availability is still very vague. And as we're approaching September, and this opportunity to really take advantage of the protective power of maternal immunization, that ambiguity is going to be very challenging to navigate without the ability to communicate confidently. So I think we'll get into it, and I want to hear your thoughts.
I agree. So my thoughts are, right now, I talk to everyone about the vaccine and the fact that it's there. And it's not because I've given this talk or was on the advisory committees, because as a parent, and as someone who's had patients who tell me about RSV burden, I need to let them know there is an available option right now, that the minute their baby is born, it will be protected. If there is no stock of nirsevimab, just like there wasn't this past year, and they have no access to nothing else, I think that's a shame. I think that we have to use every option available. And if the patient doesn't want it, that's great. But I want to do my due diligence to tell them this is what's available. It's clear that in the NACI statement that in Ontario and Canada, I'll tell you why I say that, you can still get nirsevimab if it's available publicly. Great. There's no harm. In Quebec, they won't give you nirsevimab. I think that's just a cost strategy. They specifically are using the approach where nirsevimab will be a public health approach strategy. But if a parent has chosen to get the pregnancy indicated vaccine, they will not get nirsevimab in Quebec. I don't think any other province will follow suit.
I'd say in Ontario, it wouldn't even be possible due to our
it wouldn't be possible
public record.
Exactly.
And so
I think you mentioned that.
Yeah, like really no opportunity to use any sort of record keeping apart from, patient attestation. So, in that, ultimately, I think it would be very challenging to validate whether or not someone had been immunized and then, deny publicly funded nirsevimab if that is the direction Ontario goes. So from a practical standpoint, if someone is very pro immunization and says, I'm not sure if nirsevimab is going to be available, like ultimately protecting my infant is exceptionally important to me, and a bird in the hand is worth two in the bush. So let's go ahead with immunization. This is something I can do. I know in this moment that I can take action, and I don't want to be in an instance where the day comes where my infant is born, I don't have access to the other options, and now I have regret. And parental,
I think that's what we want. We really want to avoid that.
Yeah.
I'll give you another example. Like, I follow patients with cystic fibrosis. I am offering them this vaccine. To me, it's, again, offering them, telling them about it, but some of them may not know what the risk of having a child affected with it if they haven't done paternal testing. So the fact that there is an option that is available is important. So I talk about it to all of my high-risk patients. And let them make those decisions. I had people drive to the US this past winter to get vaccinated once they were informed about all this. So the last point that I like to make here is not to make any assumptions. Someone may choose, even if they don't have insurance coverage, to pay for this. They may feel like this is a worthwhile investment for their families. And also the reason I think category 3 here, this recommendation is important, and having the individual make a decision and be informed, is that as a parent, one may choose to take the vaccine themselves and offer the protections and then give an injection to their newborn. So those are all things that I think we should keep in mind and make sure the autonomy remains in decision making.
Absolutely. And I think too, when we consider, some of the potential alternative, birth sites and how we support individuals, in all ways they choose to bear children, that, going through the options and not taking that paternalistic approach with women, I think that, comes up in the NACI statement, even with the challenges that we still have in medicine in some of those approaches. So, truly shared decision making. Ultimately, I think, the pharmacy purchase cost of the Abruzvo is as well as the alternative agent for the adults. They're priced the same at about $242 to be purchased from our wholesaler. Of course, there will be things like dispensing fees and some markup on top of that. But where private insurance plans do cover vaccine, I think many of them are picking this up as part of that class and category. So there are some nuances, of course, for the prescriptive authority that we'll get into around whether or not vaccine is funded based off of a non-prescriber's recommendation in a Schedule II product. But this product at this point in time does require a prescription. So, in the cases where private drug plans do cover vaccine, it will often be funded in that way as well too. I think, we talked a little bit about the program introduction, looking at being a potentially staged approach depending on supply, cost effectiveness, and affordability. And I think, the key here is right now, we don't necessarily know what Ontario is going to do at the programmatic level. So when you have that opportunity going into the fall to have this conversation, to advocate for immunization. I know that both Darine and I participated on a task force that looked at specifically the 24-25 season and is recommending that providers specifically discuss and recommend the maternal immunization for patients because of the current availability of the product and the knowledge that it's available to be used to be protective for this upcoming RSV season. Ultimately, when we look at the very high risk individuals who may receive palivizumab, they would still receive PAL if the nirsevimab is not available for this upcoming season, but that does exclude the primarily the lower risk cohort, but it still presents that high disease burden and the high hospitalization rates. Okay. I think ultimately we've gone through what the priority 1 and 2 groups are, so I probably won't spend any time on this slide, just in the context that we've got a lot of other valuable content to go through. So ultimately, I'm going to take a quick peek. If there are any questions right now around the NACI guidelines, I think just to review, ultimately, they are likely to evolve over the coming months and years. And we will look to that availability of ongoing evidence, as well as the opportunity to have those programmatic level decisions. But at this point in time, the recommendations are that if available, nirsevimab would be preferred over maternal immunization. That maternal immunization may be offered. That there is no safety concern around the idea that infants may have received antibodies through maternal immunization, but also received nirsevimab after birth. In Ontario, we don't have the opportunity to validate. So likely, if there is a publicly funded program, regardless of maternal immunization status, infants that, where the parents would elect to provide nirsevimab, they would still receive it. And so in that case, if an individual was very, concerned about, the infant receiving, both immunity through maternal immunization and monoclonal antibody, that could be a conversation to be had. But at the end of the day, it's not likely that we would go the route of Quebec and excluding infants from the monoclonal antibody administration because of maternal immunization. From a practical standpoint, so what is this going to look like, given the, sort of different scopes of practice of individuals who interact with pregnant individuals who may have that opportunity to have these types of conversations. So as I think I mentioned before, RSV immunization in totality, regardless of the population, is a product that requires a prescription currently. So in the vaccination space, vaccines are typically scheduled based off of their inclusion in most or all publicly funded programs. Those vaccines typically are made non-prescription or Schedule II, still require the assessment, but don't actually require a prescription order for the product. At this point in time, RSV vaccine is not included at that level, and as well as not been classified as one of those disease states where there is significant public health burden or sort of emergency need to schedule this product as a Schedule II. So just of note, pharmacists do not have the ability to prescribe RSV vaccine. So you would need a prescription from an authorized prescriber. That could look like a physician, a nurse practitioner, or as newly minted as this year, our colleagues in midwifery practice, and midwives do have prescribing authority for their patients. So that's fantastic news from an access standpoint. OPA still advocating very hard for prescriptive authority for pharmacists because that assessment for administration as well as prescribing is a very, very similar, if not identical, thought process. In terms of the administration side, pharmacists do have the scope of practice to administer RSV vaccine, of course, to those individuals aged 5 and up. So if the monoclonal antibody is classified as a vaccine, as a vaccinating agent, even then we would not be included in the administration to infants, based off of the scope of practice currently, with the age of authority for administration being 5 and up. Midwives, of course, do have the scope of practice to administer RSV vaccine, and that's great news as well, with the opportunity to administer Tdap and to look at co-administration around that 32-week period. Pharmacists also do not have scope of practice to administer Tdap, so we wouldn't be able to either access the product from the publicly funded stock or administer it without a directive or direct order. So it really does sort of limit the opportunity to take advantage of co-administration with Tdap, COVID, flu, to have that sort of full suite of immunization options available to a pregnant individual all at once. In terms of the product itself, it's 120 micrograms of stabilized prefusion F protein, 60 of the subgroup A and 60 of subgroup B. It's a 0.5 ml injection, and it comes as a lyophilized powder for reconstitution. As we've posted the link to the reconstitution, it does have a vial adapter with the diluent supplied and syringe. So it's really, it's a good idea to review that video prior to first administration. And ultimately, it's, from someone who has done high volume vaccinations, the vial adapter and administration options is really, quite nice and elegant from that standpoint. So people who do a large number of immunizations should be happy with the product presentation itself. One thing to mention here, just when we think about the available RSV products, it's non-adjuvanted. And that's typically the strategy in pregnant individuals to not typically, use those adjuvanted vaccines. But because the indication is also for older individuals, there is sort of that nuanced difference in the older adult population. This is not the scope of this talk. We will talk about RSV in the older adult population later, but with the trade names of both products, beginning with A, not necessarily, being interchangeable in that sense, I think it's just really important to consider the opportunity for incorrect administration of one product to perhaps the maternal, the alternative product to the maternal population. So just in terms of labeling and safety and ensuring that you're using the correct vaccine in the pregnant population, just really critical given that opportunity for errors. They are priced identically. So if you're thinking, if, for example, you work in a primary care office and in terms of, stocking or choosing product, you could immunize both the older adult and the maternal population with one vaccine and not have to carry both. From the pharmacy standpoint, if one product is prescribed over the other, you cannot interchange from that standpoint because they're not interchangeable, and we don't have prescriptive authority to adapt in this sense. If it was written as RSV immunization, you could choose either product based off of the indicated age for an adult population. But just from that technicality standpoint, because that we do have the opportunity to also immunize adults with the product we're talking about for pregnant individuals, I think it just sort of bears mentioning, even though it's not technically the scope of this talk. So just in summary, we know that RSV has potentially serious consequences for infants, especially in the first 6 months of life, and especially in those high-risk groups that are deemed priority 1 group as per the NACI recommendations. Active immunization of pregnant individuals protects infants in the first few months of life when their vulnerability is the highest and is highly cost-effective. The maternal vaccine demonstrated high rates of efficacy and a favorable safety profile in the Matisse phase 3 trial. The guidelines recommend in the US seasonal maternal vaccination, and the British guidelines advise a year-round maternal vaccination program. In terms of the opportunity to immunize individuals in Canada, if it's not part of a publicly funded program, it would be really a shared decision-making process and having that conversation with pregnant individuals as to whether or not they'd look to immunize off-season if it was more of an elective decision and not a program-level recommendation. So, Darine, I know you had that slide about co-admin.
Yeah, but I'm just wondering if there's questions. I think there's slides that are left are really more if there is a discussion that highlights it. I think it's more important to have questions and so on, since we already kind of mentioned co-administration in our slides. So was there any questions, or I didn't see anything while you were chatting in the
yeah.
If people were waiting till we finished talking, we'll take a
Maybe
pause.
if you want to highlight some of the resources that we discussed the other day in terms of how to support individuals with their immunization journey.
Yeah, I think those are more important. So I'll skip through this, but just to say that one of the most important things that we want to be working towards, and I speak on behalf of myself as an OB-GYN, because I think some people here may have different experience. We as OB-GYN need to understand that maternal immunization is now part of our practice, and to be part of that lifelong recommendation for vaccination. So that's something that's new to us. It's not new to our midwifery colleagues to the same extent, because they follow mom and then baby and postpartum, and to family care, primary care providers and pharmacists who deal with all of the different lifelong kind of trajectories. So this is really important. We're now participating in that initial phase in the long-term health for both mom and infants. I really like some of these tools, and I think what I think we need is to have our own toolbox. Like, what are the toolbox that we keep in our practice to show our patients when we're counseling? So over the COVID-19 pandemic, I referred to this toolbox a lot of One Vax, Two Lives, so that people can see really good material, well developed, to understand the effect of maternal vaccination. Maybe not as relevant at this point for RSV and Tdap, but certainly still important to improve and promote that lifelong vaccination. Really important to address what are the barriers to vaccinations and understand where they're coming from, so that we can help answer questions. So I think I would just tease those out. And I'm going to skip to one Ontario specific thing and something more national. So the OMAMA Act from Born Ontario has developed an immunization component with all the immunizations that are approved to be used in pregnancy. And the material is going to be vetted and getting more and more updated, and something that some of us are involved in helping support. So I think this is a good tool to guide patients to, if they have questions, say, oh, you should download this app and then look at their immunization schedule. It's also got a lot of other information, so it'll be very valuable. So as you can see, there's different chapters. The Can Immunize app is something that many of us use. It's to record our vaccination schedule. It doesn't get delivered to ministry. It's just something that you can have on your touch of your fingertip if you don't have your yellow booklet with you, and you can understand if there's anything coming up, and it gives you reminders and such. So we're hoping to work with them eventually and get some more funds to look at a vaccination and pregnancy chapter, where a pregnant person could start their record there, and that vaccine uptake that she had in pregnancy could be transferred into the history of their infant that they record after. I think that will solidify the intervention of the vaccination in pregnancy, and they really understand that it's an important intervention. So those are the tools I thought. I have questions here if there is need to create a conversation. It sounds like there is a question, so we can start there, but I'll leave it there. Yeah.
I was just going to point out there is a question in the chat about an expectation. Is there an expectation of a publicly funded program coming to Ontario?
Yeah, so we haven't heard anything specifically. It's coming. I can maybe share what I've heard, and Jen, if you've heard other things, let me know. Given the way the NACI statement's prepared, a lot of the public health units have looked at this, and there is going to be a recommendation to move ahead with the nirsevimab as a publicly funded available strategy for all infants is the goal. There's negotiations being done, of course, for having the stock and cost and availability, but I believe that is what we're going to be hearing. I don't know how they're going to talk about the recommendations then, specifically how it involves the RSV vaccination, and whether they're going to mention it at all. That I'm not sure of what will be the direction there, but that is what we expect at this point. I don't know, Jen, if you have other thoughts to add there.
Nothing really to add there. I think, even with, the recommendation, when we think about the RSV program in long-term care homes and retirement homes, high-risk retirement homes last year, and really how the implementation failed, I would just sort of stress that with the rollout of these new programs, things like supply, the provider education and the rollout doesn't just turn on 100% day one. And I think that's where we need to be really cognizant.
Yeah, I think we're worried about the timing, right? Too, like I just heard that it's coming and we're in June, it hasn't been published, and then where is the availability? Having said all that, that is the strategy that we expect. But in the interim, we kind of have these recommendations to talk about. The strategy of nirsevimab use has been what France followed as well. That's what they did this past year. They've now updated to have a twofold strategy with both the vaccine and nirsevimab because of access and like actual implementation and so on. So I think that will shift as well. So that's currently what, so stay tuned. I know that every time I see a public health email, I'm like, is this the one? But not quite yet. Is there another question, Kathy, that I missed?
I don't see another one, no.
I just pose one more to you, Darine. In how, if you had the question of somebody coming to you around the statistical imbalance, what would be some of the communication strategies, and how would you position that with the individual who's bringing that up? Because I have a feeling that will be probably one of the most challenging things to discuss with individuals, without sort of a prepared strategy on how we address those concerns.
You mean the statistical imbalance of
preterm
or the preterm birth?
Yeah.
So the way I would address it is to actually take out the document that I have printed out on all the countries' preterm birth. I know it's a lot, but I tend to just go through that and show them that there was no signals anywhere else, and show them what the numbers, which are small, look like in those two countries where there was a signal for preterm birth. I would show them when it happened, and then I would say it was a puzzle. They looked at different strategies, couldn't explain it, but it wasn't significant, and these are the numbers of the whole trial. What does it mean to you? And the reason I do the same thing with prenatal screening, right? Because it's numbers, right? Your test is negative, but it doesn't mean you can't have a child affected by Down syndrome because it's 1 in 598. So I show them the actual numbers and tell them the risks. I think it's going to be tricky for the patient that's stuck on it, just like I think I've seen it with the scientist or physician that's been stuck on that one thing and thinks it's really, really important. As a statistical interpretation, there is no significance. These numbers are not clinically significant, so should not affect a wider range worldwide strategy. That's how I would simplify it then.
Yeah, I think, it's also in the context of any immunization, like to immunize is a choice, right? And there are risks associated with making a choice, but there are also absolutely risks associated with making the choice to not immunize. And I think that risk analysis that patients often don't typically think about, they just think, really in terms of, if I'm doing something, then I have potentially, chosen a path that causes these things. So, to choose to do nothing is also a choice to accept the risks associated with doing nothing.
Yeah, no, exactly. So I think we would just walk them through the data.
I'm just looking at the time here. We're just a little bit over.
Okay.
But I do want to thank you both for presenting this very interesting and timely information. And I want to thank Pfizer Canada again for providing us with an education grant to be able to bring this session to everybody here. Thank you again, and we hope to hear more about this, and we hope that the audience has taken what they need to help their patients throughout the rest of this year. Take care.
That's great. Thank you. Thank you.